Good morning. I would like to call to order the Joint Subcommittee on Human Services. Secretary, if you can please call the roll.
Senators Canizaro, Dondero Loop, Stone, Titus, Wen, Assembly Members Brown May, Dickman, Hafen, Hibbets, Howdigi, Monroe Moreno, Yeager, and Chair Mosca.
And I'm here, and if you can please mark the other members present as they arrive. Thank you so much. I'd like to remind everyone to silence their cell phones and electronic devices, and that public comment will be available at the end of this meeting. We know that we're going to have a very busy hearing, so we're going to try our best to keep everything snappy, as well as hear from all of our public at the end. There will be 5 budgets that we are hearing from the Department of Health and Human Services, Aging and Disability Services Division. Presenters, you may go direct, and we will stop after every budget for questions. So with that, our presenters may come to the table, and please remember to state your name for the record and restate it every time you start. Thank you so much.
Good morning, Madam Chair and members of the committee. My name is Dina Schmidt.
And if you don't mind going a little closer, sorry, it's a little low.
Is that any better? It feels very quiet. It's very,
Oh, there reset.
okay.
We can't hear anything.
We are working on the sound right now, so we'll take a 1-minute recess. Thank you.
One, two, three. Is that better?
Thank you so much. We can hear you better, and we appreciate that. You may begin, and I'll come back to order. Thank you.
Okay. Good morning, Madam Chair, members of the committee. My name is Dina Schmidt. I serve as the Administrator for Aging and Disability Services Division. And with me today to my left is Carrie Embry, our Governor's Consumer Health Advocate. And to my right is Ricky Robb, our Deputy Administrator. So we'll get started. On the first slide 2 is our mission and vision. Our mission is to empower individuals and their support systems by providing resources for disabilities and aging and connecting Nevadans to the services they need for improving their quality of life. And moving to slide 3, you'll see our organizational chart. This does show the proposed IDA Part C transition is the only major change to our organizational chart. Moving to slide 4, we did create this slide just to give folks an idea and a visual of the populations that we serve and where our programs overlap amongst those populations. So several of our programs serve children as well as adults as well as seniors. Some serve individual populations and some serve all. Moving on to slide 5, this is our budget by funding source. Couple highlights here that I would like to point out. You'll see a reduction here in the federal funding. That is a removing of the ARPA funds. So it's not new funds going away, it's just the ARPA funds that were reduced or gone that we've spent. Second is Medicaid in this chart is also considered in the other category. So our Medicaid funding does not show as federal. But what you will notice on this slide is there is a significant increase in state general fund, about a 45% increase, a $234 million increase in our state general fund request. There's several factors leading to this change. One being rate increases that were approved last session in our developmental services caseload, and we'll be talking more about those at our next budget hearing. Second would be the Federal Medicaid Assistance Program, the FMAP. It has been reducing, as you've heard in other hearings, and so that is causing an increase in general fund request. And third, which is probably the number one factor for us, is our caseload growth. The demand for our services just continues to rise year over year. And just to give you some statistics to help highlight that is, there's an estimated 269,000 people in the state of Nevada that are over the age of 5 who have some form of disability. And approximately 2.3% of the state's population experience difficulty with performing activities of daily living, such as dressing, bathing, getting in and out of their own homes. The population, the over 60 population in Nevada, is expected to reach 17% of the total population by the end of this year. Between the years of 2012 and 2022, the population of adults 60 and over in Nevada increased by 42%. This population growth continues to put pressure on all of our state resources, including our social service systems, our transportation systems, our medical systems, our housing, and our workforce. As this population ages, the demand on our budgets, which is the majority of caseload, you'll see throughout this that our budget is caseload. That is what we do in aging and disability services. And so as the population continues to get older, we have to find ways to solve this problem and address the demanding needs. And I would just say that I feel like I'm getting older along with all this population. So 2 reasons I bring this to your attention is, one, to help this body understand that difficult decisions have to be made when there's limited resources. And secondly, that we need to work together to determine how to address this demand, as it is expected that we will not see a slowdown in this increase in any time soon. According to the Elders Count 2023, we will continue to see an increase in older populations for the next 25 years. So we're seeing a current growth in older populations right now, but there's also a swell of individuals in their late 30s right now that in 20 years from now, they will all be in this next generation of growing older adults. So with that, would like to move on to slide 6. This is just our budget by summary by budget account. And then on slide 7, we will start with our actual budgets. So budget account 3151 is our administrative budget. This is our HR, IT, fiscal services, as well as positions that are cost allocated across the program to manage programs across the division. On slide 8 are the decision units related to this budget account. First being E259, which requests for a medical epidemiologist. This position will focus on improving health outcomes and mitigating strategies to decrease the impact of substance abuse and opioids amongst older adults and adults with physical disabilities. SAMHSA, according to SAMHSA in 2019, 1 in 50 individuals 60 and over has an opioid use disorder. So that's the purpose of this position, is really to help us focus on what that impact is on the older population and how do we intervene and come up with effective treatments and interventions to reduce opioid abuse amongst older adults. The next decision unit in this is E499. This is just a continuation of our ARPA funding to continue our system modernizations. We were granted ARPA funds to do a lot of IT projects, and those are just continuing into the next biennium. And then an E900 is an agency manager from budget account 3266 to our home and community based, or from our home and community based. So this is just transferring positions, an agency manager and a management analyst, into 3151 so that they can be cost allocated across all of our programs, as both those positions serve multiple budgets. And with that, I will take any questions on this budget account.
Thank you so much for that overview and setting the stage for today. We do have some questions, so we'll start first with Speaker Yeager.
Thank you so much, Madam Chair. Thank you for the presentation. I do have a couple questions on E259. The first one I had was looking at some of the underlying documentation. It looked like this was originally proposed in the governor's budget to be, I'm talking about the epidemiologist position. It was proposed to be funded with federal Title X Social Services Block Grant funds, but I just wanted to confirm that it should be funded through the use of the opioid money, because I think that's what you said, but I wanted to confirm that was the case and just make sure that we have all that documentation correct on our end.
Dina Schmidt, for the record, you are correct. The intent is to fund this with the opioid funding.
Great. And then if I could have a follow-up, Chair. I've asked a lot of questions about the use of the opioid money, and I think you just noted that I think it was you said 1 out of 50, so about 2% of older individuals have opioid use disorder. So I guess a two-part question. One, what do you hope to accomplish through this position? And then do you have any data around that 2%? Is that prescription drug abuse? Is that, getting opioids off the street? Just any light you could shed on that would be appreciated.
Dina Schmidt, for the record, so I think you just made the point is we don't have the data on that, and that is the purpose of this position is really, we know that it's a problem among. I am not very sorry about that.
Okay,
Dina
we
Schmidt,
hear
for the
you.
record. You just highlighted the fact that we don't have a lot of Nevada-specific data. It just keeps
I'm sorry.
going out.
Do you mind using the mic, one of the mics next to you while we work on that? Thank you for your.
Blinking and an echo. Okay, let's try one more time. Dina Schmidt, for the record. So the intent of this position is to do that, is to better understand substance abuse and opioid abuse amongst the older senior population. It is an area that we know exists, but it's not talked about a lot. I would just give the example in Adult Protective Services, we got a federal grant to focus on opioid abuse. And what we saw was either abuse amongst the individual senior or oftentimes amongst the caregiver or the adult child who was then stealing from, impacting, not taking care of an older person. But there was no desire to talk about it. So it was a voluntary program under that particular grant. They had to volunteer the information. And what we found is people don't want to talk about it, and they don't want to get their adult child caretaker in trouble, right? And so what I would like to see accomplished is how do we create a system where we can intervene in that situation and help both individuals, both protect the older adult, but also get the individual who might be substance abusing into treatment without creating, without removing the stigma from that situation, because we do see that a lot. I would say, too, that we have the other concerning fact is Nevada ranks 48th for drug death over the age of 65, is how do we reduce that number? What are the appropriate interventions for this population? And how do we make a difference and bring that number down? So.
Thank you. Any other questions on the administration budget? Thank you so much. And with that, we'll go to 3204.
Dina Schmidt, for the record. So on slide 9, we move to the Consumer Health Assistance. The Consumer Health Assistance, this is our program where we have ombudsmen that guide Nevadans through accessing their health care and insurance and prescription drug assistance. This program also handles arbitrations for out-of-network emergency services under $5,000. Moving to slide 10, you'll see our caseload projections for this particular budget. This is the first time we've had caseload projections for this budget. We recently moved into a data system and are able now to project the demand for these services. Moving to slide 11, this is the arbitration. They are projected to actually start declining this year. That is because we are charging for those now, and people are starting to get the contracts, which was the intent of the program. So we are seeing a slight decline in arbitrations. Moving on to slide 12, these are the decision units for the Office of Consumer Health Assistance. M201 is the projected caseload increase. And E932 is the management analyst transition from data analytics back over to this budget account. That position really is a programmatic duties, and so we're transitioning that back to the division. And with that, I'll take any questions for this budget account.
Thank you so much. Yes, we have some questions. We'll start with Majority Leader Hedgie.
Thank you so much, Chair. Okay, just a couple of questions if I can. The first one is, please discuss the primary factors that are contributing to the increase in the consumer health assistance caseloads and how you guys are managing them and how these new positions will alleviate that.
Dina Schmidt for the record. So, like I mentioned, is in the consumer health assistance, right? We get a variety of calls. It could be from Social Security, disability determinations, how difficulties there. It could be Medicaid eligibility concerns. It could be prior authorization, specialty care. And as we know, the demand for those, the challenges around health insurance and accessing health care continue to grow, and even more so, I would say now than before. And so we continue to see a demand. And we've also done a lot of outreach in this program, which we hadn't done for quite some time, and so we kind of leveled off on our calls, but with that outreach, we are starting to see an increase in calls to our ombudsman. So what these positions will do is allow us to improve the quality of service. Cases won't stay open as long. People will get their situation remedied in a timely manner.
You mentioned, cases wouldn't stay open as long. Could you talk to us about how long people are currently waiting for services and waiting?
Carrie Embry, for the record. Cases are generally, they vary, but about 90 days is, cases can stay open to up to 90 days and sometimes longer in more complex cases. And so with the positions we have now, it varies. Sometimes the less complex cases, we can take care of and move pretty quickly on, and others, sometimes, especially with Social Security, Medicare, it can be complex cases with, we have the Bureau of Hospital Patients and Workers' Compensation. We do those as well, so sometimes those can stay open longer than the 90 days.
I just want to follow up on this question too, and then, so with the increase in staffing, you had mentioned that 90 days is the average. What do you expect that to go down to? And also, is there a current wait list for people who haven't even been assigned, like a caseworker?
There isn't Carrie Embry, for the record, there isn't a current wait list. We do have, we do initiate our cases. We have a policy for initiating cases within 3 working days. So there isn't a wait, but as the cases increase, sometimes once those cases are open and the ombuds is working with an individual, sometimes that may delay the ombuds getting back to the individual. Anyway, we can get those cases down under 90 days. Anything under 90 days, under a month would be very efficient and helpful for the consumers that we're serving.
Thank you for the last follow-up. And then just one last question. Can you walk us through what metrics you guys use and how you determined what number of cases would be appropriate for each ombudsman?
Carrie Embry, for the record. So currently, this has been part of the new database. What each ombuds has now, it is what it is because we have this group, we have 6 ombuds total, and so I do have that. I can tell you what the caseload is just to give you an idea. So currently, as of January, the caseload is 1 ombuds to 96 cases, and so we'd really like to get that down to 45 would be excellent.
Brilliant. Okay. And I guess that first part of my question was how did you guys determine that 45 cases was a good number per ombudsman?
That would greatly reduce the caseload in order for the ombudsman to give the time necessary for each individual and the circumstance that's been presented for them. So we have found that, well, for example, we have one ombuds vacancy right now, and that's part of the 1 to 96. Then it makes it more difficult for the ombuds to do outreach, which is essential to keeping the public and our healthcare providers informed what we do. So that was all considered in that 45.
I'm sorry, and if you could state your name for the record.
Carrie Embry for the record.
Dina Schmidt for the record. So I just also wanted to say that what we did is when we looked at the data and the timeframes, right, we compared it across our other programs. We have 2 other similar programs that carry similar caseloads. So our goal of getting down to that 1 to 45, 1 to 50 range is based on those other programs.
Thank you so much for the questions. Any other questions on this item? And we're learning that the mics are not just here, so we're all going to use our outside voices, so we appreciate it. And we will move on to budget item 3208.
Okay. Dina Schmidt for the record. So 3208 is our early intervention service program. This program is dedicated to helping infants and toddlers with developmental delays thrive. The program supports families in addressing their child's needs by fostering growth in cognition, communication, physical development, social emotional skills, and adaptive abilities. We cater to children under 3. Oftentimes, these services are provided in an in-home environment or community setting rather than a facility setting. And on slide 14, you can see the caseload projections for this budget account. We are seeing a slight projection of about 2% growth over the next biennium in this caseload. And then the decision units for this caseload are on slide 15, the first ones. M201 and 202 are the caseload projections. E266 is a decision unit that transitions from to a fee-for-service model for our community providers. This decision unit ensures our compliance with payer of last resort requirements, as well as ensures the maximization of federal funding is being used. E260 is a medical epidemiologist to help develop health interventions to mitigate negative impacts of opioid and substance abuse. Again, this position is also funded through the opioid funds and is really similar to the aging population, but focused on 0 to 3. And we know that 12% of the children in Nevada born have been exposed to substance abuse. And so how do we create interventions and identify services that will help those children develop and grow? And then the last decision unit here is E264. This replaces audiology equipment as well as funds ongoing maintenance and calibration. Moving to slide 16 are the additional decision units for this budget account. E253. This funds the annual purchase of protocols. We know that, like I said, 12% of newborns are affected by gestational exposure, and protocols are needed to identify developmental delays and ensure that we get children into the necessary services. So these protocols are critical to that early intervention service. E680 is an elimination of 5 positions that have been vacant for more than 2 years. And E901 is a transition of a management analyst position from the early intervention budget account to our 3151 account, again, just so that we can cost allocate across programs. That particular person works in more than one budget. So happy to answer any questions on this budget account.
Thank you. We do have several questions on this budget account, and we will start with Assemblymember Brown-May.
Thank you, Chair. Thank you for being here. Thank you for the presentation this morning. I've been told to use my outside voice, so I'm gonna work on that. I do have questions relative. There are lots of questions, and I would love to catch up with you offline about many of these. But I'll stick with caseload growth and staffing adjustments for M201 this morning. Can you talk about the current capacity throughout all the regions of the state to provide children through the EIS program for community providers through state services? What's our current capacity to provide service?
Dina Schmidt for the record. So I think one of the challenges you'll see in the caseload growth is it has been adjusting, right, from we break it out by community partner and by state. And then if you see the original projections, they've changed over the 3 months. You'll see a difference in, originally it projected that the community providers were going to take more kids. Then you see the projections that the state will take more kids. That was due to a couple of providers being out of rotation. And so just that couple months of being out of rotation, they go out of rotation for various reasons. but that will change the projection. So we try to look at the overall projection. Right now, it seems that everybody has capacity to grow at the growth rate, but probably not as fast as we would all like to, if that makes.
Ricky Robb for the record, if I could just add to that. So I think the challenge is that we do know in the last legislative session that we went from a 50-50 model to that split, that required split. And it was our hope that we would see the shift. But because we did have two, one being a much larger program being out of rotation, it made a significant shift to the state providers versus the community providers. We're happy to supply like the actual breakdown of those percentages. I do have those for you. But that is really what our challenge is this year. When we have a provider out of rotation, it shifts that the actual caseload.
Thank you. Follow-up, Chair. Thank you. So thank you for bringing that up, right? That the provider state split. In the documentation that I have, it looks like the state is working to become more of a provider as opposed to supporting the organizations that are, the independents that are outside of the state's purview. You've talked a little bit about why that happened. You had a provider out of circulation. So I just want to be clear about, is it the state's intent to grow as a provider, or is it the state's intent from your division to foster relationships with outside agencies that can deliver this service, right? And this is really from the perspective of the Interagency Coordinating Council on Early Intervention Services, right? How are we growing supports for this 0 to 3 population? And I'm just curious to know, is it going to rely on the state and our delivery, or is it going to rely on growing the network in our community?
Thank you for the question. Ricky Robb for the record. No, the state would not like to be the main source. In fact, again, my hope at this stage of where we are from last legislative session, I was hoping we'd be at a 70-30. 70% being the community providers, 30% being state at this stage within the 2 years. That was my hope with that change. Unfortunately, when you have providers out of rotation due to compliance on a long term, it impacts the entire system, and it impacts every single one of these providers, community as well as state. The other piece of that is that the state providers are the only providers who currently provide rural early intervention services. So there's no percentage that goes to the community providers at this point in the rurals. We have been in communication with them. They submit a monthly a capacity that states how much they can take during that month to bring more children into the community services. So the goal would be for them to be taking more. I know with some more discussions that we'll be having today, we'll talk about what does that really look like. But no, the goal would be that we have more. In fact, at some point, the discussion has been that in 7 to 10 years from now, the state provider looks different, technical assistance, training, and that the majority, if not all, our children are in the community.
Thank you so much. Vice Chair Nguyen.
One more, just to clarify, because you've used this term a couple of times of like a provider being out of rotation. I know that there are only 5 of these community providers. So when you say out of rotation, are they just not accepting clients? Are they no longer, do they no longer have licensure? What are the circumstances?
Ricky Robb, for the record. So typically when a provider, and that could be a state provider or a community provider, is out of rotation, it's typically due to compliance issues. These 2 particular providers that were out, so 2 out of the 5 were out of compliance and out of rotation. So that is based on IDEA Part C. And so they make those recommendations, and every child that would have gone to those community providers either go to the state or to the other community providers, keeping in mind Not all providers provide statewide supports and services. So we have a provider in the northern region that is just northern, and then we have two providers in the south that only provide in the south. So when we're looking at that, it does impact significantly. So we have seen the Las Vegas caseload grow due to having two providers out of rotation. We are looking at when they go back into rotation, we look at various things in regards to, can we return exits? So if a child exits, then we would just maintain those numbers. So just know it comes together with Aging and Disability Services as well as the IDEA Part C office. We work collaboratively in determining what that looks like. Please know it is one of those, as Administrator Schmidt spoke about, those tough decisions. We never want a provider to go out of rotation. That's the last thing we want, because we've also seen programs go out of business in those scenarios as well. So our goal is for them to get into compliance as quickly as possible, ensure they're serving quality services to those children and families, and move forward. So the last thing we want is, because it impacts the entire system, and I can tell you the state staff is saying, when can we get a break on this as well?
That kind of transitions back to this, and also what you had indicated, that it is not the state's intention to take over these services from community providers. And I know in speaking with community providers, obviously you probably have heard some of the testimony that began early on, even in our subcommittee, our early, pre-session meetings, from public testimony and comments. We're getting a lot of feedback from community providers that were under the impression, like you had indicated, that there was actually going to be a move to move more towards these community providers and providing these resources. And they actually planned accordingly to be able to take on those increased caseloads. And with the shift in the payment model, I know that there's a lot of concerns from these same community providers that they're not going to be able to maintain their business model, and they will not be able to take on these they won't be able to, they won't be able to afford their existing caseloads, let alone take on, a projected increase up to 70%. Would the state be able to take on these added people if come July 1st, these community providers realize that this is an unattainable situation and we had to shift all of those resources over to the state at this point?
Ricky Robb for the record. Again, another one of those very difficult decisions in this budget process. To answer your question in short, obviously with caseload, we would have to. Federally, we are required to not have a wait list. As all of you know, and everyone that we work with understands, that Nevada is facing the same national critical shortages that everyone else is. Nevada, it gets hit in different ways. So would we like to take on these additional children? No, we would not. We would like to ensure that they are able to stay in the community with these current community providers. We have other interested providers as well. But no, we will make capacity because we will have to. We're the safety net. And as the safety net, we have requirements that we need to meet, and we will do everything that we need to do to ensure that those children are receiving the best services that they can. Again, will that be an impact on the system? Absolutely. And we would prefer that we find a way to maintain all of our community providers and grow that network for them, and ensure that those children are in the community.
I guess my other question is I'm hoping I can get some further clarification. I know that during one of these initial presentations, there was an indication on the record that only 6% of the community providers were billing in this situation. And it's my understanding that maybe there was some, I guess, there was, it should be, it should be restated, I guess, for clarification. So if you could clarify kind of what you meant about 6% of these providers billing on these, on these, children, I think that would be very helpful for the
Dina
community.
Schmidt for the record, so since I'm the one that made the statement, I will be the one to clarify. We track billable and the claims coming in 3 different ways. So all of us, including the state as well as the community providers, we bill private insurance, we bill Medicaid, and we bill managed care. So we do track it by all 3 of those. And so the percentage of reimbursement varies across each of those. So the lowest is the Medicaid fee for service. That is where the 6% comes in. The average is 6% return on fee for service. What I didn't understand or state on the record, which I would like to clarify now, is that only represents about 4% of the total caseload. The majority of the caseload is managed care, but we're still not seeing anywhere near the goal, which is a 98% reimbursement rate for services under managed care as well as private insurance. So we have provided staff with a breakdown of those percentages across every program. So I don't want to go into detail and go into them on the record, but I think we have provided staff so that you have clarification of exactly what those numbers look like.
So the 6% was really of that 4%. So it was a very small proportion. And while we are not at maybe 98%, it's my understanding that we're closer to 60% in billing at this point.
Dina Schmidt for the record, so I think across all of it, we might be closer to 60%, but I would just keep in mind that at $795 per child per month, regardless of for an open IFSP, right? Those are state general funds going out the door that we're not getting the federal dollars back on, which is really the intent of this transition. And I think secondly is just the purpose of this transition is to get us into compliance. It's not to do harm. If we need to work through what this looks like, we're willing to work with this body to make sure that we aren't doing harm, but we do have to make sure that we're being compliant with that payer of last resort rule that does require us to ensure that billable services have been reimbursed before we pay any supplemental or additional payments.
What type of, I'm sorry, Chair, may I ask him, what type of resources are we providing these community providers? Because when you're talking about having to submit for reimbursement or payment for services to these MCOs, much like I would have to do, there's a lot of denying of these services. There's a lot of denying of these process. And so we have these unrealistic expectations on our community providers to be able to provide these services for our 0 to 3 year old population, and then also try to navigate the insurance world of denials and repeated submissions of services. I mean, there's a very good realistic possibility that a service that is submitted for reimbursement at 6 months won't even be paid by the time that child ages out of the program at 3 years of age. So what kind of services is your agency taking into consideration as you're proposing to transition to this model where they are completely dependent on insurance companies approving every single claim that they make?
Ricky Rubb for the record. As some of you on this body will recall, we have gone through multiple iterations of trying to build a comprehensive billing and data system. We're currently in what we call the NEED system, and it's Nevada Early Intervention Data System, NEIDS, and it went live December 1st of 2023. Just let me know with challenges. We've been working through that process. But as we have found, we had to build a system that was appropriate for Nevada, because our billing processes are different, and also because of Nevada's structure with having community providers and state providers, that also added an additional opportunity for us to work through. And so within that system, all providers are billing in the NEED system, so community providers as well as state providers. And so we've really worked to find the best way possible. Again, it's not perfect, but we're working through it every day. So with that system, we did multiple iterations of training in person. We do ongoing supports on that. They have what we call kind of an open house, open office, where they bring their questions. We work through it. They work one-on-one with our fiscal staff when a program has concerns. We're currently having every other biweekly meetings with Medicaid for them to ask specific questions. We've also done those introductions to ensure that they're working directly with Nevada Medicaid to ensure that they're able to get those questions answered directly. I think one of the bigger challenges is the private insurance. And so we've been able to support somewhat, but I would say that's going to be, all of it's going to be ongoing. This is not a one-time fix that we can give an answer and move on. It's going to be something that the system has to do together on the forever at this point, no matter what we're doing. But the system, we also, just so that you all know, in regards to some of the opportunities that we've had with the system, is we keep a record of all of the tickets and tracking and the issues that come in from any provider, and then we work ongoing with the vendor. I can tell you in my experience in doing vendor projects, which any of you that have done those know that they're not very fun, honestly. And typically when you're a year out of go live, you no longer have weekly meetings with that vendor. We continue to have those weekly meetings based on ensuring that when those issues come up, we can have those conversations. And I am the one that has the tough conversations if that vendor isn't meeting what we need. So again, it will be ongoing. I hope that I answered your question. Oh, I just wanted to, the other piece of that. So when that 794.88 was determined through the Burns and Associates study in 2022, that 794 is inclusive if a child has all services. So I think we want to keep in mind that 794.88 is if a child is receiving speech, OT, SI, all of the proposed services for a child with early intervention. And some of these children might be seen once a month, or they might only be receiving service coordination. So I think we have to keep in mind that there is that potential for not overpayment, but for a lack of a better word, some months that's going to get maxed out with a child. Some months it's going to be less if they only are being seen once a month. And so just keeping that in mind on that 794.88. The main piece for this is compliance, and compliance with Medicaid as well as compliance with the payer of last resort. We've been working with federal experts, and I just want to say that they stated to us, we are surprised Nevada has not had a finding on your payer of last resort. Our goal is to not have a finding on payer of last resort or Medicaid payments.
Thank you. Next, we have Senator Dondero Loop.
Thank you very much. I don't know if it's working or not, but I have a teacher voice, so it's okay. Good morning, and thank you for being here. The caseload staffing ratios that would result in the elimination of the 2 administrative supervisors and 5 administrative support staff. So both those positions, both the supervisor position and 2 of those 5 administrative support positions are currently filled. So with the M201 would not eliminate the 2 filled supervisor positions, but it would eliminate the 2 filled administrative support staff. So what is the rationale for retaining that supervisor position and eliminating the 2 frontline administrative support positions that are currently filled?
Thank you for the question, Ricky Robb, for the record. So keeping in mind, those particular positions are based on caseload. And so at the time of the caseload that I believe it was the November projections, it looked as though our caseload was going down. So should our caseload continue to increase, as you saw that right now it's really looking at a 2% in the next biennium, but we are seeing that increase right now, especially with those providers being out. It could could show that those would go up and then they wouldn't be eliminated. However, if that caseload does not change and we still have to eliminate, we would look within the division if there's another position that we could put them in, since it wouldn't be able to be maintained within budget account 3208, and then or in the department, and then ultimately, if we cannot find them a position, then they would go on the layoff list. But we do everything we can, and very seldom do we actually have them go on the layoff list. One, because Hope caseload maintains, or two, because we're able to put them in another position within the division or the department.
So with that being said, will that will continue to fit in the budget then?
Ricky Rob, for the record, only if our caseload shows that we will have the increase and that we need those positions. As of right now, it's not in the budget because it's not projected in our caseload.
Okay, thank you. Follow up, Madam Chair? Yes. So could you also discuss the addition of the psychological development counselors and the health program managers to the caseload staffing ratios that will benefit the children with early intervention services?
Absolutely. Ricky Rob, for the record. So as Administrator Schmidt said earlier, we do caseload ratios. And so within the caseload ratios that we have for early intervention, and we've been doing this for several years, it now shows us when we need additional management or supervision, and as well as our developmental specialist. So this actually shows, based on our caseload, based on the supervision that we currently have, that we need that additional support within, currently it's within the northern region, and that's based on growth. And the northern region, again, supervises the entire rural northern region. And again, those are areas that are just state-provided services in the rurals. So it really just supports that actual caseload.
Thank you. And you may have sort of answered this with the earlier questions, but so what impacts does the agency anticipate on state capacity to provide service as a result of those, of the recommended caseload positions? Does that make sense?
Will you repeat the question, please?
What impacts does the agency anticipate on state capacity to provide service as a result of the recommended caseload positions?
Ricky Rupp, for the record, on those administrative, we would shift duties. When we get in those situations, sometimes a developmental specialist would help take over some of those duties, or supervision, depending upon what the actual position is and what they're doing. So we would shift duties.
Okay, thank you very much, and thank you, Madam Chair.
Thank you. Speaker Yeager.
Thank you, Madam Chair. I have a few questions on the community provider payment model changes in E266, and specifically about the add-on payment that's coming from the Fund for Resilient Nevada. So I guess my first question, do you anticipate that those add-on payments would be continued into future biennia as part of the budget, or are they intended to be temporary for this transition during the 25-27 biennium?
Ricky Rob, for the record, so $199 of that add-on supplemental payment is actually state general fund. 88 to 120, depending upon the year, is set to be a temporary payment through the Fund for Resilient Nevada opioid settlement funds.
Oh,
Okay,
Thank
so maybe I'll. Yeah.
However,
you
my
got it.
mic
Thank
is
you.
on. Support
Okay.
you.
So my apologies. Now I just got distracted. Ricky Rob, for the record. And so yes, as of right now, those are set to be a temporary transitional payment from the Fund for Resilient Nevada payment. The other part is currently in the budget and would be for ongoing.
Okay, thank you. That makes sense. And just a couple more follow-ups on that. So I understand that the temporary part is from opioid settlement funds. How does the use of that money align with the goals of the opioid needs assessment and statewide plan when it comes to this particular budget account?
Thank you for the question, Ricky Robb, for the record. Really, when we are seeing that 12% of Nevada's infants are born exposed, this really helps us, one, in that transition, and it identifies that we have a population that we probably have not been supporting as well as we have in the past, because as we all know, our populations have changed significantly over the years. And so it's really important for us to ensure that we're hitting that goal number 3, which is to reduce harm, and really, which is one of our one of the main pieces of early intervention is we're trying to reduce harm of these individuals, these children who are prenatally exposed, and so the goal would be to be within that goal 3, reducing harm, which also goes into all of the opioid settlement funds that we have requested, is to ensure that we're within supporting those children, those babies, those in uteros that did not have a choice, and to support them in finding resources and adequate and appropriate services.
Thank you, Chair. And if I could ask a couple more just on this topic. I think you explained, sort of the rationale, but I'm just curious, and I could be mistaken about this, but I didn't see that particular funding reflected in the Early Intervention Services budget account. Should it be reflected there?
Gina Schmidt for the record. So you're talking about that supplemental temporary payment?
Yeah, just a supplemental 8394 in 2026 and 12072 in 2027.
Gina Schmidt. So yes, that is not intended to come through Aging and Disability Service because of its temporary nature. It will come directly from the director's office.
Okay, great. And then one last question, if I could, Chair. Could you explain what the process is going to be for providers to request and receive that particular add-on, the opioid add-on? How is that going to work? Is it going to happen automatically, or is there going to be a process in place where they request that?
Thank you for the question, Ricky Robb, for the record. It'll be similar to what they currently do. I'll be honest with you, we're still in process in making sure what that looks like going through the director's office. Our goal is to have it actually probably streamlined through us when they submit their other invoicing for either the 794 for uninsured or for their monthly unbillable and the 199 on our side. So our goal is to do it the same, but then work with them so that they don't have to submit it in multiple places. So our hope is to streamline that and to ensure that, we work with them closely so that it doesn't add another administrative burden to the provider, and that we work directly with the director's office to get that.
Thank you. And now that we're back on the payment method change, I do have some questions. And I understand what you're saying is it's compliance driven, but what does the agency foresee that this could impact community partners when it comes to things like capacity, client services, or wait times?
Ricky Robb, for the record. Unfortunately, there could be the impact. And I know they're very concerned about this. We've had these conversations. I think the challenge, so in all transparency, the challenge is we knew this would be coming at some point. The unfortunate part is the planning part wasn't there for all of us. So it's an impact not only to them, it's also an impact to the state in finding the process and working through that. So this is one of the, I will say for me in my career, one of the toughest decisions I've had to make in working through this. So please know we have empathy and compassion for them as business owners and the highest of respect. As I have said many, many times, this system is reliant on the community providers who provide services. They provide quality, and they are good at what they do. So on that note, our hope is that we can find a way to support them. And if this is an okay time to say, I would love to look at a potential insurance assistance type model that we have similar to the Autism Treatment Assistance Program. Being able to look at those high deductibles. should our finance body have funding somewhere that we would be able to do a high deductible plan. Obviously, it would be stringent. We would have to have proof that, you know, what their deductible looks like. I will not get in, it's shutting me off, so I don't get into those details. But ensure that, you know, we have a process. So that's one thing that I feel that if we worked with them and we could find something to do with the high deductible, that would be something. We make sure that if someone does not have insurance. So the goal is to have the limited harm and to work with the program.
I appreciate that, and I think every time your mic goes off, mine goes on. So thank you for that.
And mine's on now.
I appreciate your perspective, and you started to. It's just important for all the community providers we're hearing from. You know, how do you plan to continue to work with them in this transition?
Ricky Robb for the record. Well, first, communication. I will say that we understand people are frustrated, but they also have to continue the communication with us. We're out there, we're talking with them, and we need to keep that going. Without that, we won't succeed in any opportunity that we have before us. So that's our goal, is to continue that communication. We are meeting biweekly with them. You know, we have Medicaid that comes as well. And so, but that communication, that collaboration is going to be key on both sides.
Thank you.
Dina Schmidt, if I could just add, I just want to clarify, we are working closely with Medicaid, and they have been a great partner in coming to the table to work with and listen to these providers regarding the payment rates, as well as any of the challenges that they might be having with managed care. And so they are stepping up to the plate to assist us as well. So it's not just ADSD, it is Medicaid also assisting along the way.
And we really agree with these mics. We'll go next to Vice Chair Nguyen.
I think they answered my questions, actually. Thank you, though.
Thank you so much. I believe next then we have. I believe next it's Assemblymember Monroe Moreno.
Thank you, Madam Chair, and hopefully my mic will stay on. I'd like to go to E260, the medical epidemiologist. Could you explain how the addition of this position to study the impact of opioids might contribute to the overall improvement of health outcomes for newborns and developing children, and discuss the nexus to early intervention services?
Ricky Robb for the question. Thank you. I have to tell you, this is frustrating. Oh, geez. Okay, Ricky Robb for the record.
Yeah, thank you. We'll actually take a 1-minute recess to see if we can
Thank
figure
you.
this out. Thank you. Thank you, members.
She has no computer right now.
Oh yeah, well, that Medicaid, I had it in my head, so I'm so glad that you said it, because I was like, I lost
Wondering
it.
what happened when they came and got your computer. I'm like,
I know. I'm going back.
And we do refer, the nexus is that we.
you know, I.
And our presenters, they are working on it. We don't have an update right now, so it may be a good time for a bathroom break, but don't go far.
Thank you.
Okay. Oh, I'm holding the mic now. Thank you, everybody, for your patience. It's not just our room, it's all the committees right now that are going on. So we're going to take a 15-minute recess. We're going to come back at 9:15. They're going to reboot all the systems, and hopefully that will solve it. So please come back by 9:15. Thank you.
My mic light. It's so weird because this is not work. Like, this is not a new system. Like, right? Push it to somebody else. Bother them again, and they're on over. Anyway, thank you.
I don't know. I like the pain.
Like.
Thank you, everybody, for your patience. We're about ready, so we'll give members about a minute or two to return, and we will begin. Okay, thank you, everybody. I hope you enjoyed that little break, and we will continue on and make sure we have the time we need. So we will go back to Senator Nguyen. Thank you again, everybody.
Thank you. Oh, look, we're working again. Temporarily. It's not flashing up here like it was all morning. So I'm kind of going to switch over to some of those maintenance of effort requirements as a part of the federal IDEA Part C program. Can you provide an update? Because in my looking at it, it looks like, obviously we need to maintain certain levels of funding, and it kind of looks like we are not. So I'm wondering if you can provide an update on the guidance that you received from the Federal Office of Special Education Programs regarding early intervention services and our ability to meet those federal maintenance of effort requirements, so we're compliant with the federal billing.
Dina Schmidt for the record. So yes, we have met with the Office of Special Education, as well as they referred us to a national expert who was able to answer some of our questions and give us guidance on how to comply with the MOE requirements. One of the things that we talked to them about, and that they provided us a clarifying document explaining that one of the things that the state of Nevada has not done previously is you can claim the state share of Medicaid and you can claim the state share of admin expenditures. So there's a large portion of funding that we have been leaving on the table for years that we are able to. So as some of these payments transition to the Medicaid program, while the Medicaid payment itself from the federal government is not countable, the state share of that payment is countable. That is something we have never really been utilizing and claiming, so we can certainly start to look at those claims, as well as all the administrative costs in aging and disability services. Historically, we've only calculated the service dollars, and so we have quality assurance teams, we have management teams, and so administrative costs to operate the program, our fiscal team, are all allowable expenditures. So we believe with those additional, counting those additional ones, we'll be able to meet MOE. And then secondly, we did ask the worst question of all, right? What if? What if we fail to meet it? What if we miss it by, And what she told us was that the Office of Special Education would, if we failed to meet MOE, would give us a finding and a corrective action plan and work with us to resolve the issues. But she said this isn't the first time states have had to go through this transition, and that they anticipate we wouldn't get a penalty right off the bat. So.
I don't know if that gives me comfort. We wouldn't get a penalty right out the bat. But I guess that kind of, do you have an idea of when that new calculation, being able to use those previously unused numbers in the calculation of that maintenance of effort, like funding required, will you have a better idea of what that means and how that will change ultimately how much is required?
Dina Schmidt for the record. So the requirement is that we calculate the final, so when our budgets are closed and all costs have been accounted for, that's usually about a 2-year lag. So we use that 2 years. We don't know what this budget looks like yet. And so once the final determination is made on our current budget, it's hard to say whether we know what that number is, but we don't know what this number looks like yet. And we can start to run those numbers and project the additional costs. But it's really difficult at this point to project the state share of the Medicaid payments because they haven't historically been coming in, so we don't have a lot of data on that. So we are trying to work together to figure out how we calculate this because there's a lot of unknowns at this point until the budget is actually finalized and we know what general fund appropriations there are for this program.
Thank you. And just kind of shifting over to there's some vacant position eliminations in E680 to kind of shift our thinking here and some of the positions we're talking about. I know that there's a recommendation to eliminate a vacant developmental specialist position. I guess how would that, obviously it's vacant. I don't know how long it has been vacant, so maybe you can answer that. But how would that impact the ability, agency's ability to provide those early intervention services to all children in the projected caseload for the upcoming biennium?
Ricky Robb for the record. So those positions that are slated to be eliminated at this time are ones that have been vacant for more than 2 years. Simple answer.
And Dina Schmidt for the record, I might just add the two you asked specifically about the developmental services. There's 2 positions that we understood were eliminated last session. So we had not attempted to fill them. And that's why they're slated to be up for elimination.
Sorry, Ricky Robb for the record. I would love to keep them.
You'd probably love to fill them is really what it is. But I guess that kind of answers my next question just about, obviously it sounds like there's the capacity and there's the work to be done by those positions, but you've just had a difficult filling those positions. Is there anything, obviously there's a recommendation for elimination as it hasn't been filled for the past 2 years, but what are the barriers in filling this position?
Ricky Robb for the record. Well, those particular positions that you referred to, there wouldn't have been a barrier to fill them. At this point, we have one DS. We are at a 3% vacancy rate in early intervention, and currently we have the caseload for it. So I don't believe we have a barrier, but the reason why those particular ones weren't is because our understanding is they were to be eliminated, so we did not recruit. I do believe if we recruited, we would be able to fill.
Thank you so much, and thank you, members. Any other questions on this budget item? Well, thank you. And with that, we will move on to 3209.
Dina Schmidt for the record. So moving to slide 17, we're now going to talk about budget account 3209, which is our autism treatment assistance program. And as most of you know, this program supports essential therapies like applied behavioral analysis and social skills, intensive parent training, and speech, physical, and occupational therapies to children under the age of 18 that have a diagnosis of autism spectrum disorder. On slide 18 is the caseload for our autism. We do project about a 12% increase over the next biennium for this program. And then on page 19, there's the one decision unit for this program, and that is the caseload decision unit M201 and 202. And with that, I'm happy to answer any questions with this budget account.
Thank you so much. We will go to Senator Don Loop.
Thank you very much. Can you talk a little bit about whether the agency anticipates sufficient autism service provider capacity in the upcoming biennium to support that projected caseload?
Thank you for the question, Ricky Robb for the record. we are continually working to increase provider capacity for all services, autism included. So at this point in time, we do have some wait times for providers, but we're increasing provider capacity at all time. Can I tell you that it will meet based on a 12% projected increase? I'm not sure at this time, but we continue to increase providers.
Thank you very much. Follow up, Madam Chair. So can you talk additionally about that caseload staff and how that might help reduce the number of children waiting for services, as well as wait time for children to begin receiving autism services? I know that we have, the village out there, but can you kind of bring that in for us and talk about that?
Ricky Robb for the record. So yes, if we have the staffing, that really supports the families on the case management side and giving them that service coordination. And so they do support those families in finding appropriate providers. As new providers come on, they're able to identify what would fit for that child and that family. So yes, the staffing is key to ensuring that we were able to connect those families to services.
Do you have an estimate or a number of how many families we're currently serving and how many might be waiting?
I do. Currently, we have 1,077 who are active, and then we have 334 who are waiting.
Okay, thank you. Thank you, Madam Chair.
Thank you. Members, any other questions on this budget? Thank you, and with that, we will move right along to 3282.
Okay, budget account 3282, Dina Schmidt for the record, I apologize. 3282 is our adult protective services and our long-term care ombudsman programs. In our adult protective services programs, we safeguard vulnerable adults from abuse, neglect, and exploitation. And in our long-term care ombudsman program, we champion for the rights of residents in long-term care facilities. Moving on to slide 21, we start with the adult protective services caseload. We anticipate in adult protective services about a 5% caseload growth over the next biennium. And slide 22 is our long-term care ombudsman projections. While this one does see a projected increase of 16% over the next biennium. And then moving on to slide 23 are the decision units. These are really, again, caseload, as we know. Aging and disability is all caseload. So M201 is the projected caseload for adult protective services, and M202 is the projected caseload increase for long-term care ombudsman program. And with that, happy to answer any questions regarding these programs.
Thank you. We will go to Majority Leader Hennigy.
Thank you so much, Madam Chair. Can you hear me? Good? Okay. Thank you. And questions about caseload again. And so I just want to ask, can you talk a little bit in depth about the primary factors that are contributing to the increases in the caseloads for the adult protective services and the long-term care ombudsman program?
Dina Schmidt for the record. I'm going to start and then I might have to pitch to Carrie here. So adult protective services, right, is based on complaints. And so we have seen an increase in complaints or allegations of abuse, neglect, and exploitation. Same as our long-term care ombudsman program. They go out to facilities on a regular basis, not with the intent of doing an investigation, but what happens sometimes when they go to visit a facility, they might, in educating clients and residents of those facilities, they may get issues that arise. And a resident may say, I don't get to eat at 9 o'clock at night when I'm hungry, or whatever the issue might be, right? So sometimes that will also, so we get the adult protective service, we get the referrals for long-term care ombudsman in multiple ways. Sometimes it's us going into a facility, sometimes it's an individual calling us, sometimes it's a family member calling to make a complaint about their loved one in a facility. So we've just seen a rise. I don't know that I know what the indicators are, if it's low staffing in facilities or what it is. We don't correlate that to what the issues are. So I don't know what the rise is for long-term care ombudsman. Perhaps Carrie knows more about the adult protective services program.
Carrie Embry for the record. I think part of it is just seeing our Nevadans continue to age. We have a high number of cases in the age group of 74 to, it's either 80 or 84. So there's a high number in that. Also, in Adult Protective Services, we have completed a media campaign. So we've been getting the messaging out. What are the signs of abuse? How do you report? And so that, I think, has been part of it too for Adult Protective Services.
Thank you. And just to follow up, how are the staffing ratios for managers and supervisors, quality assurance staff, and administrative staff determined to be appropriate? And why are the legislative approved staffing ratios not working?
Ricky Rabb for the record. I would say caseload. We are really seeing increases in numbers across the board, anywhere from developmental services to early intervention. Autism treatment assistants literally received 96 referrals, which is much higher than we've seen in the past. So I would say ledge approved is based on projections. Actuals are coming in higher.
Thank you so much. Next, we have Assemblymember Monroe Moreno.
Thank you, Madam Chair. Staying in the same arena, what's your existing vacancies for the Adult Protective Services and the Long-Term Care Ombudsman Program?
Dina Schmidt for the record. So in our Adult Protective Services, our current vacancy rate is 30%. Social workers being 37% of that breakdown, and adult rights specialists being 17%. And in our long-term care ombudsman program, our current vacancy rate is 21%.
And continue. Thank you. So how are you managing the growing caseloads with those existing vacancies?
For Adult Protective Services, we are doing a number of things regarding recruitment of those vacancies, both for the vacancies. We are working closely with our universities, University of Nevada, Reno, University of Nevada, Las Vegas, in going into their classes, talking with the social work students. We are participating in any type of job fairs that they have at the universities as well as in the communities. We're also taking Adult Protective Services takes in practicum students at Aging and Disability Services Division. So these are some of the things that we're doing, and it is helping to make a difference. I thought I would share that since July, the vacancy rate for Adult Protective Services has come down 15%. And so we do feel like the recruitment activities that we're doing with our universities and out in the communities is making a difference in beginning to bring the vacancy rates down.
Madam Chair? Thank you. So you spoke about recruitment. Are you doing anything for retention?
Yes, Adult Protective, Carrie Embry for the record, my apologies. Yes, Adult Protective Services is focusing on retention. We do this a number of ways. One is through supporting our staff through training, and another thing that we're doing as well is as we're onboarding our new staff, really working with them. We have a social work academy that both the social workers and adult rights specialists go through, so that we really work to try to train them so that they go out in the field with confidence, knowing what their role is and what they need to do. So hopefully that will help them, with staying, enjoying their job. They know what to do and how to do it, and have the support of their supervisors.
One last question, ma'am. Thank you. So having the 15% lower is great, but what is the actual ratio, knowing that you still do have the vacancies and they have a caseload? What is that ratio?
Carrie Embry, for the record, can you clarify?
The ca-
The case, okay, it's currently 1 to 54. Okay,
Thank you so much. Thank you, Madam Chair.
thank you.
Thank you so much. And members, any other questions? Okay, well, thank you so much. We first, of course, thank you for all that you do for our state, and we are so appreciative of your patience today with the mic. So thank you so much again. So now we're on we'll close the budget hearing, and we're on our last item of the agenda, which is on public comment. Because of time considerations, public comment will be limited to 2 minutes. I will be taking time and let you know if we're over the time. Please state and spell your name for the record. And if you are in Carson City to do public comment, you can start filling in the rows. If you are going to call on the telephone today, please call 888-475-4499. When prompted, provide the meeting ID and enter 865-5788. 6981, and then press pound when prompted for the participant ID. So we will start here in Carson City. Don't forget to state and spell your name, and you may begin.
Good morning, members of the committee. I'm Mike Wilden here today. I'm with the Perkins Company and helping the Early Intervention Community Providers Association try to get through this budget task. Just want to make a couple quick comments, and then I'll turn it over to Mr. Burns and Julie Ortiz. I just want to make sure from the testimony that we all kind of understand Nevada has had what we call this gross case rate system, the 795. It's been paid at different rates for years, but we've had the gross case rate system in place for decades. So hearing testimony that it needs to change, yes, it may need to. There's 2 studies that you can look at, 2 Burns and Associates studies that have been done in the last 3 or 4 years, and they've recommended things, but they have said to stay with the gross case rate study until there's a plan to move to fee-for-service. I don't think there is a plan, and I think in the testimony today there isn't a plan. The 795 should be considered as like a managed care payment. Some kids cost a lot more than $795. Some kids cost less than $795. So it's not every kid is less than $795. Some are many more that need those services. Billing. It sounds like there's an impression that the community providers are not billing. They bill every day. They bill Medicaid, they bill the MCOs, they bill private insurance, and when they get payments, it's netted out of their $795 payment. They don't get to keep that. It's netted out currently. If we go to the other model, the fee-for-service, and when they get paid $199, there's a $600 gap between $795 and $199. You will not see insurance collectible at $600 per month per kid. It's not going to happen. If you look in the Burns study, it says the national average is a 16%.
We are at 2 minutes. We
okay.
thank you so much.
I'll stop. Thank you.
Thank you. We'll go to our next speaker.
I need to turn on the mic. For the record, Robert Burns, and I'm current president of the Nevada Early Intervention Community Providers Association. Good morning, Madam Chair and members
And
of
could you spell your name for the record?
Robert, last name Burns. Thank you. Good morning, Madam Chair and members of the committee. I'm a pediatric occupational therapist and have served as such for the state of Nevada since 2005. I worked for the state's NEIS program for 5 years before leaving to start Therapy Management Group with my other 2 co-owners whom I met while working at NEIS. We saw firsthand many of the challenges NEIS faced, for example, staff shortages, increased bureaucracy, and a wait list with over 500 kids. Nevada Disability Advocacy and Law Center filed a system-wide complaint due to the lack of a timely initiation of services. In response, the state contracted with a community provider, but it was very expensive. So in 2007, TMG presented a proposal to HHS that suggested all EI services be delivered by community partners, with the state retaining management, oversight, and quality assurance. And in 2009, we were awarded a contract to become a community partner. At that time, the community partner's rate was $767 per child, plus insurance revenue. that worked, the wait list was eliminated, and more children were seen. During the last biennium, an independent rate study was conducted. The rate study found that community partners should be paid $7.95 per child per month minus insurance revenue, and the legislature approved that new rate. But now, in spite of that study's findings and the legislature's rate approving a drastic rate, though his decrease is being proposed, which would make it impossible for community partners to keep doors open. And over 1,800 children would be returned to the state and wait list for services. In closing, to avoid that, we humbly suggest these three solutions. Return the $12 million annually to the budget 3208, category 14. Continue to make changes to need software to enhance billing, reporting, and efficiency, and fund an additional study before changing to a fee-for-service model to assess cost, viability, and impact to families. Thank you.
Thank you so much. Next.
Thank you. Julie Ortiz for the record, Julieortiz. I am a member of the Early Intervention Association as well. I'm a speech pathologist, but I'm also a business owner of Advanced Pediatric Therapies. I've been in business for 22 years. We do speech, PT, OT, autism services, behavioral health, and now early intervention for the past 16 years. So I've been with this program a very long time. I've seen a lot of positive changes. We've worked through a lot of growth and challenges as well. This is probably the biggest challenge that we've had to think about adjusting to, because this rate, without changing a service model, it cannot work. This rate of the $199 is more a clinical model, clinical-based model, where we would see children back-to-back in a facility. This does not support a home health model. The other challenge that we face with it is the majority of the services we provide as early intervention providers are not billable. We have those federal unfunded mandates that we provide to the families to ensure quality and that they're receiving all their rights of care. We cannot assume we can run a position just with insurance billing. There's been talk about non-compliance with billing. As a provider, we understand the payer of last resort. As Mike and Rob said, we bill the insurance. We pay that fully back to the state program, and then we receive their payment for that payment of last resort. So we are following that model already. What they are proposing is a drastic cut to what we will be getting paid back in return.
Thank you so much. And before we continue here, if you're in Las Vegas to testify, you can start filling in the chairs. Next here, please.
For the record, my name is Deborah Stewart, MD Developmental Agency. Can you guys hear me?
Yes, and Ms. Stewart, if you don't mind, please spelling your name for the record for the secretary.
DebraStewart. And this is my first time here, but this issue is very important. I am from Chicago, Illinois. We have a program in Illinois and Nevada. I am also a developmental specialist and a psychological counsel and behavior certified specialist as well. I would like to talk about challenging with the Nevada EI data system needs. The statewide system has been in place for 15 months and still have a full-time project manager and weekly meetings with state administrators to work on ongoing errors and limitation in the system. Community partners are giving feedback and are engaging in the process of improving the needs system. ADSD is providing framework for the community partner to report errors and glitches in the system. Some improvement recommendations include the capacity to rebuild denials or bill secondary insurance without manual submission in order to decrease denials, tracking private insurance deductibles, create standard insurance report and private insurance remittance integrated to improve tracking of claims, authorization, and payments.
Thank you so much. And we'll go down to Las Vegas. I think there are more people up in Carson City, but for efficiency, if you can go ahead and fill the chairs. So in Las Vegas, if you can go ahead and start.
Garten and a graduate of all Nevada schools, including UNR. Currently, I'm the president of the local nonprofit Family to Family Connection.
I'm sorry, did
founded
you
in
state your
1990
name and spell it for the record?
Sure, Karen, Karen Wilkes, Wilkes. Family to Family Connection was founded in 1998 by First Lady Sandy Miller. The program provides education to children 0 through 5 via the concept of family engagement. The parents must help their own child with prescribed activities, therefore becoming the child's first teacher. We're teaching parents appropriate ways to interact with the child, working with approximately 200 families per year. We're currently partnering with UNLV and Touro University to take their early childhood development advanced students as interns at our program, providing them with their practicum hours. Our employees are trained to spot medical and psychological problems and to make referrals. We rely on philanthropy and fundraising and county funds. If we can reach 99,000 children in Las Vegas who are not in daycare prior to kindergarten, it will change the graduation rates and the abilities of our workforce in Nevada. Family to Family would like to help by expanding to 8 locations around the valley, potentially reaching 1,600 or more families per year. These 8 locations could be accomplished for under $1 million per year, and think of the impact to our community. We're supporters of this bill of moving funds to community partners. That would be good for all of us. And thank you for the opportunity today to speak about our growing community-based service.
Thank you so much. I know there's one more person in Las Vegas. If there's anyone else there to testify from Las Vegas, please fill the chairs, as well as anyone here in Carson City. You may go next in Las Vegas.
Good morning. I'm Dana Aronson, DanaAronson, one of the owners of TheraPlace Solutions, an early intervention community provider serving over 200 families and member of the Community Providers Association. Thank you for the opportunity to be here today. As you consider the budget, you will hear compelling information about why the proposed drastic funding cuts are unsustainable for the early intervention system. Today, I want to provide you with specific funding data that highlights just how unsustainable these reductions would be. Our analysis, based on 182 active children, shows the following. Current funding at the capitation rate of almost $795 costs the state $144,688 per month. With the proposed decrease to $199 per child, TheraPlace Solutions would receive $48,252 per month. To put this in perspective, the proposed model would not cover payroll for our providers before taxes, not to mention employee benefits, administrative expenses, and other operational overhead. Additionally, if this budget cut is implemented, children enrolled with community EI providers would be forced back into the state-run program at an increased cost of almost $51,000 more per month compared to simply maintaining current community provider funding. This is not just a funding issue, it is a fiscal and human impact issue. The proposed cuts will push children back onto wait lists, delaying essential services during their most critical developmental years. Eliminate parent choice, forcing families to rely on a strained state system, and cost taxpayers significantly more in the long run. I urge you to prioritize the well-being of Nevada's children and families by rejecting these cuts and ensuring sustainable funding for our community providers. This
Thank
is
you.
an investment in our children's
Thank you, and you can
future.
always also submit it for the record, and we appreciate you being here. Next in Carson City.
Hello, my name is Mark James with Therapy Management Group, for the record, MARKJAMES. I appreciate this opportunity to speak with you today. We've been around a long time and wanted just to give a little bit of history. Since 2006, a gross capitated rate has been used in early intervention to reduce and contain costs of early intervention services. Whether a child receives 1 service or 20 services per month, the cost to the state is the same. Over the past 16 years, community partners have received reductions in the gross capitated rate with no reduction to required services provided to families. The gross capitated rate has been adjusted from $8.57 per child per month to $6.95 to $5.65 to a prorated $5.65. With all these reductions in payments, it became very difficult to be competitive in retaining and hiring staff. Thanks to the legislators' efforts during the last biennium, a rate and service model study was commissioned. The study found that the state's cost to provide services was over $1,000 per child. And the authors recommended that the community partner rate be placed at adjusted to $7.95. With that rate adjustment, we have been able to actually take on more kids, hire staff, and retain staff. So we've been very excited about the direction of early intervention. So this was quite a hit with the news to this current budget. In closing, over the last 15 years, the state has never made a change without doing a study first to assess the proposed changes' impact on families, cost, and any other unintended consequences that might affect the early intervention program's viability. Thank you.
Thank you. Next.
For the record, my name is Patrick Santoro. I'm with Therapy Management Group, PATRICKSANTORO. Previously, community partners were paid $5.65 as a supplemental rate per month and allowed to bill insurance to recoup therapy costs. In 2022, HMS Burns study stated that a $5.65 rate was not a viable number moving forward. The rate study did recommend a comprehensive rate of $7.95 with insurance reimbursement netted out each month. In a perfect world where 100% of insurance reimbursement is received and no family cancels appointments, the proposed supplemental rate of $199 or $287, along with insurance reimbursement, still wouldn't cover the cost of payroll, let alone the full cost of the program. Thank you.
Thank you so much. Thank you all for being here. Seeing no one else in either Carson or Las Vegas, AVH will please go to the phone lines.
If you'd like to provide public comment, please press *9 to take your place in the queue.
Thank you and good morning. I'm Connie McMullen, spelled Connie, C-O-N-N-I-E, McMullen, M-C-M-U-L-L-E-N. I'm here on behalf of the Senior Coalition of Washoe County and Senior Spectrum Newspaper. We support the budget for aging and disability services for the upcoming biennium for adult protective services and the Ombudsman program in long-term care. These are extremely valuable programs in safeguarding our aging population. Our membership supports spending and caseload growth, bringing down wait lists, and the time spent waiting for assistance. Administrator Dina Schmidt reported there will be a continued growth over the next 25 years in vulnerable and aging populations. Now is the time to get ahead of this expanding need. We thank you for your consideration.
Thank you so much. Next caller, please. We hear some background noise. If you're on there, caller, can you please state your name and spell it for the record?
Yes. My name is Lisa Manning, L-I-S-A-M-A-N-N-I-N-G, and I am the Chief Executive Officer of Capability Health and Human Services, and we're one of the first community providers to provide early intervention services in the state of Nevada. We are concerned that the proposed funding cut, coupled with the shift to a fee-for-service model, will create untenable financial and operational conditions for community providers. If the community providers are forced to close, families will be left without access to critical early intervention services. This will lead to large waiting lists, or NEIS, a burden that the state program is not equipped to handle. There is lack of evidence supporting the fee-for-service model. The fee-for-service model's efficacy and viability have not been studied or substantiated as a better way to move forward. We propose that rather than reducing funding and further straining the system, we urge to adopt the agency request for Budget 3208, which restores the necessary funds and maintains the current capitated rate for CPs. Additionally, we propose that funding be sustained at the current levels until a comprehensive study can be conducted to evaluate a viable operational and financial model for delivering these services. This study would provide data-driven recommendations to optimize service delivery while ensuring fiscal responsibility. The early years of a child's life are critical for their development, and reducing access to EI services contradicts the goal of providing children with the best possible start in life. I respectfully urge you to consider the long-term impact of this on Nevada's children. Thank you.
Thank you so much. Next caller.
The public line is open and working, and there are no additional callers at this time.
Well, thank you so much, everybody, for your time and your patience today. We appreciate it. And with that, this meeting is adjourned.